subscribe now and press the bell icon. Never miss an update.
Hello and welcome to Health Live at Seniors today, our first session of this calendar year 2024. We have here with us Dr. Rajesh Jaria. Dr. Jaria is a senior physician with the Hinduja hospital. He has been managing intensive care since 1999. He's had more than his fair share of ICU rotations at JJ hospitals. He's further honed his skills in Singapore and later worked as an intensivist in Mumbai, where he set up a liver transplant ICU. He has been closely associated with cardiac surgery team and has handled post-cardiac surgeries at key hospitals in Mumbai. He has a special interest in diabetology and endocrinology. Dr. Rajesh Jaria is a specialist in internal medicine, and today we have invited him because the month of December was observed as a constipation awareness month, and this is a common problem with seniors. So we've invited Dr. Jaria to speak about constipation, and he's here with us. What is all this about the COVID situation? Is it really as bad as we think it is?
No, not really, actually. We haven't been having too many patients coming in here. And even in all of India, there are only 760 patients at this moment in time as of today.
All right. Yeah, you being at Hinduja Hospital, and Hinduja Hospital is one of the leading hospitals in the country. And if you're saying that, clearly it means that, there's nothing much happening. Sorry, I'm back now. Sometimes these things happen at some times. I just couldn't see you. So I'm going to make you the co-host so you'll be able to speak. So that's good news. But do you think people should be masking up any which way? We have all senior citizens here.
At least the ones who are at risk should, but otherwise not really.
But tell me something. Yesterday I was at a meal at a dinner table, and there was somebody sneezing. And in the good old days, in the good old days, 2 years back, if somebody did sneeze, one would just perhaps run away. Now,
the table would be empty after some.
The table would be empty. Is that something that one should be worried about?
As of now, no, I don't think so. Not in the current situation. Because most viruses, especially this virus, it doesn't want to really kill the host, because when it kills the host, it's killing itself. So it doesn't want to increase its virulence. It only wants to increase its infectivity. So it's giving mild problems to people, all who have got it till now. We don't really have any significant, patients getting into the hospital or dying because of this. So it's like a cold now, any common cold at the moment, at least.
Right. Doctor, over to you. I've made you co-host. You can be...
Thank you.
The thing, as you are aware, Dr. Jaria is going to be speaking about constipation care. Those of you who have questions, please put them in the Q&A tab. Mention your age and your gender, and we will pose the questions to Dr. Jaria.
So do I start?
Yeah, please go ahead and start. Thank you.
Thank you. So welcome, everybody, especially Mr. Maheshwari. Thank you very much for this invite, and thank you for having this organized. Constipation. Very good topic. I wonder who chose it. Whoever did really has chosen a topic which is very good, because these are issues which are real and nobody seems to be wanting to discuss them. So I'm glad that this topic, which is very, very common and which really needs a bit of discussion, has been picked up. So what is the German word for constipation? And I'm sure this joke will not be lost on many. And this is something that you might want to hear. Recently reported its top constipation. So constipation is a common condition. It has many widespread notions with no basis in fact. The purpose of this meet is to explore current scientific knowledge on that subject, connect that knowledge with daily life, and summarize lifestyle modifications that might be needed. We hope to help knowing symptoms which constitute constipation, understanding the causes, the diagnostic studies, the identifying incorrect notions, advise treatment for constipation, and most important, avoid Himalayan cures for constipation. So, constipation essentially can be acute or chronic. Acute in medicine is something that happens suddenly, where in a short span of time, and needs to be sorted immediately, because otherwise the patient is in discomfort, significant discomfort. Acute constipation is actually a redundant term, because if it is acute, by definition, it's not constipation. It's just something that has happened for a momentary period. You treat it and it gets sorted and it doesn't come back. That's acute. So it's not, there's really nothing like acute constipation. What really is there is chronic constipation, which is a definition. So, definition of constipation, by definition, it has to be chronic. It has to be something that is occurring for quite some time. And so chronic constipation goes under numerous names, alternative designations, something like irregularity of bowel, sluggishness of the bowel, intestinal hypomotility. There are different terms which people use to describe it. And the treatment of constipation with bowel movement inducing procedures and medications does have a long history. I mean, it's not something that we have seen in recent times. It's not a modern problem. It's a problem since time immemorial, since human beings have come to live on this earth. And many unproven notions, some of them which are really false, are in circulation even today. And some of these notions are present. I mean, they're given by regular doctors. And when polled, 10 to 20% of people in general population state that they suffer from constipation. But there's a big difference, between what they define as constipation and what doctors define as constipation. So why is it so important? Essentially, it affects quality of life. It affects so many things. It affects vitality. It affects daily functioning. It affects physical roles. It affects your emotional state. It can give you bodily pain, and in general quality of life. So the magnitude of the negative impact was comparable of constipation to that seen in patients who have severe allergies or who have musculoskeletal conditions, or then of course inflammatory bowel disease, which can be also equally harassing, if I may use the word. So take-home message for this much part is that constipation needs to be defined in the patient's own terms. Patients and doctors define it very differently. Constipation is a symptom and not a diagnosis in its own right, and it has significant adverse effect on a patient's quality of life and their ability to function normally. So this is something that many of us have seen and heard, and we do know that at the end of the movie, when he doesn't have any complaints of constipation, actually that's also the point where he says bye-bye. So constipation affects a lot of patients, and we need to address it with a certain amount of respect. It's a constellation of symptoms. Fewer than 3 bowel movements per week. That's the traditional definition. A feeling of fullness, that's what most patients will define. The need to strain in order to have a bowel movement. There is no minimum stool frequency required for health. So there is an apparent dichotomy here, right? Where I'm saying fewer than 3 bowel movements per week, and then I'm saying there is no minimal stool frequency required for good health. So this is true. There was one patient of mine, a British gentleman, would pass stool only once in 7 days. Absolutely fine, all reports fine, never had any discomfort, never felt any discomfort, never complained about any discomfort, lived all his life. All this happened for 40 years that he was living, and all his medical conditions were, medically, he was absolutely fine. So there is no minimal stool frequency. Even once a week is fine if the patient is fine. And even, less than 3 a week is not good if the patient is not feeling comfortable. So it depends upon the patient's comfort level, the patient's complaints. Only 1/4 of all patients have fewer than 3 bowel movements per week. Some worry that their stool frequency is too low and they fear self-poisoning. Long time stool remains in the body, they fear that this might cause them to be poisoned. But actually, obviously, this has no real basis in fact. And for most patients, the chief complaint is either a feeling of fullness or a need to strain in order to have a bowel movement. So these are the two real complaints. And many times these complaints may be present without necessarily being underlying, there being an underlying pathophysiology or a pathology. It's something that can be psychological, many times is psychological. So as that point said, that only 1/4 of all patients actually have fewer than 3 bowel movements, but many of them will still complain that feeling of fullness and a need to strain. So diagnosis of constipation comes from the Rome criteria. At least 2 of the following symptoms are required to have been present for at least 3 of the past 6 months. So as you can see, 3 of the past 6 months automatically makes it something chronic. Straining at stool for at least 1/4 of the time that the patient passes stool, hard stools at least 25% of the time, feeling of incomplete evacuation at least 1/4 of the time, a feeling of anal blockage 1/4 of the time, manual maneuvers for rectal emptying at least 1/4 of the time, and 2 stools or less per week. So if you have any 2 of these, then you would get classified as per the Rome criteria, as having constipation. And the last 4 symptoms usually also indicate that there is an impairment in defecation. So constipation can be because of colonic issues. It can be because of defecation issues. If you have feeling of incomplete evacuation, anal blockage, you need manual maneuvers to get your rectum empty, or if you have 2 stools or less per week, this could indicate that there could be an impairment in defecation. If you look at what's most bothersome to patients, then straining is very bothersome. Hard, lumpy stools, and more people report these, straining and hard, lumpy stools. Some talk about incomplete emptying, stools cannot be passed, abdominal fullness and bloating. And the doctor definition commonly used by physicians, less than 3 bowel movements per week. And of course, then there is manual maneuvers. So Rome diagnostic criteria for functional constipation, loose stools are rarely present without the use of laxatives. Insufficient criteria for irritable bowel syndrome. So many times patients feel that this might overlap with inflammatory bowel syndrome or irritable bowel syndrome, but usually they are 2 distinct criteria. Acknowledge that there is a significant overlap which exists between functional bowel disorders like irritable bowel and constipation. So many times patients who have irritable bowel may then feel a sense of constipation when they have a silent phase, which doesn't necessarily mean they have constipation. Abdominal pain or bloating may be present but is not predominant, and supports the concept that functional constipation and constipation predominant IBS exist as a continuous spectrum. So those become special cases. Physiology of defecation and normal colonic motility. I am going a little fast because I have to finish within the next half an hour. If in case you have any question or you feel something is not understood, you can note it down and we'll clarify it later. So physiology of defecation and normal colonic motility. We have the process of defecation, we have normal colonic motility, segmental and propagated activity, we have transit times, we have bowel frequencies, and we have stool consistency. So physiology of defecation and normal colonic motility is that basically there are 3 types of activities or 3 types of movements that occur in the gut. There is segmental activity, which is different parts of the gut at around the same time may contract and cause a certain amount of movement of whatever is inside to propel whatever is inside towards the exit, right? These are usually small movements, short time movements, but they come frequently. There is low amplitude propagated contractions, which their main function is to transport fluid contents within the colon. And they've been associated with distension of the passage and passage of flatus, right? High amplitude propagated contractions usually are strongly associated with defecation itself. So that is when you feel those mass movements in the sense of wanting to pass stool. That has high amplitude propagation of the colon. So these are the 3 types of movements that might occur in the colon. They do occur in the colon, and these are the ones that help you eventually to move food which has got absorbed and whatever is left over as stool to move forward and come down eventually to be passed out of the body. It's a complex process, right? There's a lot of interplay. There is gut movement that occurs. There is pelvic floor movement, evacuation that has to be done, which means voiding, whether it's passing urine or passing stool. Pelvic floor muscles play a big role. Neurological facets, and when there is sensation and then there is a response to that sensation. Motor function, which means the actual movement of the gut. There is a social context. You have to be in a situation where you might want to be able to pass stool. So if you are in a situation where you can't pass stool, then you might feel yourself constipated. And there is an emotional context, because emotional context is also equally complex, but I'm not going to discuss that in detail. Control of defecation is mostly subconscious, but there is conscious control also involved. So in the morning, when you feel like going to the toilet, most of the times the point till which you feel like going to the toilet is subconscious. And then after that, when you feel that, oh, now I need to go, that part is where consciousness takes place. Conscious control comes over, and you have to find an appropriate time when you can go into the loo. Awareness of the urge to defecate results from stimulation of stretch receptors. So that's what we discussed, that there are neurological facets of sensation which are involved. So there are stretch receptors that are present in the rectum. And when feces are delivered from the sigmoid, these afferent impulses subsequently are sent to the brain. And the brain then says whether we can now pass stool or not pass stool. So that's where the conscious part takes over. Faces are retained until there is an appropriate time for voluntary contraction. Contraction of the rectal musculature and relaxation of the internal sphincter results in local reflexes and prepares for expulsion of feces. Sorry. And then eventually other changes take place in musculature which are complex till eventually defecation occurs. So let me take you through the process of defecation. Now, the important thing in the defecation which you need to know is that there is an internal sphincter, an internal anal sphincter, and there is an internal anal sphincter, and then there is an external anal sphincter. You can see these purple colored muscles which constitute the external anal sphincter, and these here are the internal anal sphincter. So both of these have to relax before defecation can occur. So this has to be done as a coordinated process, along with a stool getting pushed by the colon above. So there is a common discussion whether the Indian style of toilet is better or the British style of toilet is better. So squatting is considered as better because the puborectalis muscle, as you can see, this muscle which works like a sling, when that is relaxed, then passing stool is easier and there is less straining. So how does that work? Suppose you're sitting on the left side. This is how you would sit on a British style, and on the right side is how you would squatty potty. You would sit in the Indian style. So just to enlarge it, you can see that the sling is pulling more tightly on the left side when you're sitting on the pot. But if you're sitting like a squatty potty, or if you're sitting in a squatting kind of position, the sling has loosened and even the colon has become more straight. And therefore, when you sit in a squatting position, it is far easier to pass stool and much more effective. Defecation is much more effective. This is again showing you the same thing, but this is kind of summary of defecation, that there is a sensory perception of stool, there is rectal distension, the diaphragm and abdominal and rectal muscles contract, and there is the sphincter, the external anal sphincter, where decreased pressure occurs, and there is a relaxation of this muscle, which is called the puborectalis muscle. And if you are squatting, then obviously this will relax much more, right? And if there is defecation that is not normal, or which is called dyssynergic defecation. Then there is prolonged colonic transit time. There is discoordination of the abdominal, rectoanal, and pelvic floor muscles. There is rectal hyposensitivity. There is paradoxical increase in the sphincter pressure. So whereas the sphincter is supposed to relax, it paradoxically contracts harder than it should. There is less than 20% relaxation of resting anal sphincter, and there is inadequate abdominal rectal propulsive forces. So all of the motions are a little inadequate, as some of them are too little and some of them are too much when there is dyssynergia causing a defecation problem and therefore constipation. So pathophysiology of constipation. The pathophysiological components of chronic constipation are abnormal intrinsic motility. There is a lack of luminal factors, so there's inadequate stretch receptor or tactile stimulus. There can be medications which can cause this. There can be hormonal states which can rarely cause constipation. There is lack of extrinsic innervation. So, for example, if a person has a stroke, which is the type of stroke which affects the lower part of the body, and if there is impaired defecation is what we discussed in the upper slide. So if we take the first part, abnormal intrinsic motility, that comes under what is called as lazy bowel syndrome or something called as slow transit constipation. And in that, it is characterized by slow movement in the digestive system where there is reduced motility of the large intestine. It's a type of functional constipation without a clear cause. So we have not been able to identify because the musculature is fine, the neurology is fine, the nerves are fine, and yet there can be a certain slowing of the movement of the large intestine. Other types of functional constipation include normal transit constipation and defecating disorder. So lazy bowel syndrome is very distinct from defecating disorder. It is distinct from normal transit constipation. Normal transit constipation occurs when the digestive system operates normally and waste moves at a normal speed. However, stool may be difficult to pass. And this is without the presence of a defecating disorder. So this is one of the dichotomies of constipation. And then, of course, there is a defecating disorder, which we discussed about, which is defined as an inability to evacuate contents from the rectum despite excessive straining. So if you look at slow transit disorder or the slow transit constipation, the lazy bowel syndrome, it is on a background, it's a type of chronic constipation, slow movement of waste through the digestive system. It decreases motility of the large intestine, but we don't know what exactly causes this decreased motility. Sometimes there are direct causes. There could be a nervous system problem. There could be a condition called Hirschsprung disease. There could be an intestinal blockage because of a tumor. There could be a damage to anal muscles. There could be unhealthy bowel habits. So do remember that unhealthy bowel habits, if you try to stop your stool every day and you try to change your bowel habits from passing stool every day to say passing it once in 3 days, you can develop lazy bowel syndrome. So unhealthy bowel habits is something that you have to guard against because otherwise it can lead to chronic problems. There is also other indirect causes that like eating disorders. So eating disorders where patients eat much more than they should. And so there is the sheer content that the gut has to deal with is far higher and is not able to live up to that. Hypothyroidism is a hormonal condition. IBS is a condition that usually occurs in early teen to early adulthood. And that can affect patients for throughout their life. And there is dementia, which obviously, again, boils down to unhealthy bowel habits in one sense, and that can cause lazy bowel syndrome. So the symptoms are here, which are standard: abnormal bloating, painful bowel movements, hemorrhoids, inability to control bowel movements. Lifestyle changes that can be used as treatment is light exercises, dietary changes to include more fiber, and decreasing stimulant laxatives. So one of the unhealthy bowel habits that is there is laxative abuse. And if you have too much of laxative use, you will develop this problem of lazy bowel syndrome. And therefore, one of the simple treatments for it is just reduce the stimulant laxatives that you're taking. It may take 3 to 6 months, but your bowel will come back to normal and you will stop requiring laxative, and you will also get back a normal bowel movement. Of course, can be medical therapies like bowel retraining, surgery, and interferential electrical stimulation, which can help to treat these bowel issues. And this line is just showing what is normal transit time of food through the colon. For example, in the right colon, so in the small bowel, which is the small intestine, food will take roughly about 6 hours in total, right? The proximal part 0 to 2, the mid part between 2 to 4 hours, and the distal part between 4 to 6 hours. So total about roughly 8 to 10 hours food will be there in the small bowel. And from the small bowel, it will go on to the right colon, and it'll spend about 6 to 10 hours there. After that, it'll move on to the mid colon, which is about 10 to 16 hours. And then by 16 to the 19th hour, it will be in the left colon. So it spends about 8 to 10 hours in the small bowel and roughly about another 4 to 8 hours in the large bowel, after which it is ready to leave the body. So that's the colonic transit time. Some that can go slower or lesser in some patients and more in some patients. Where it increases too much, then it can cause constipation. Moving stool out of the body takes a coordinated muscle movement. In the pelvis, the pelvic floor muscles and the anal sphincter need to relax at the right time. In this type of constipation, where there is pelvic floor muscle problems, patients feel the urge to go but have a hard time doing it, and it may be painful. Check if the patient complains of spending a lot of time in the toilet, straining and pushing to move, using fingers to get the stool out, or using enemas frequently, and finding that laxatives or fiber supplements don't relieve constipation. So in that case, it could be a pelvic floor muscle issue. People with this type of constipation often have hemorrhoids, they have cracks around the anus called fissures, and they have hard impacted stools. It's not clear what brings this kind of constipation on, but is often treated with behavioral and relaxation techniques and a little bit of pelvic floor muscle exercises, which definitely show significant improvement if the patient does those exercises seriously. These are medications that can be constipating medications. I'm not going into the details of it. That's something your doctor should know, but we do have a lack of time. Iron preparations, for example, can cause that. And so before you take an iron tablet, be sure that you're not somebody who will suffer from constipation because of tablets. So we've basically covered almost everything that is discussed over here. And so that's the pathophysiology of constipation. Just to let you know that there are different types of stools that we have classified. So there is a Bristol stool chart that has 7 different types of stool classified. And there is, in the Bristol stool chart is essentially something we apply to adults, whereas there is a pediatric Australian chocolate poo scale, which is not too different from the Bristol scale with minor differences, but it does classify stool in a different manner and is more used in children. The most desired part of a medical talk, most people will be waiting to hear this, is diet. So diet improves gut health and it can improve gut mucus, provided it's the right kind of diet. And so if you increase gut health, it basically means you're increasing the appropriate type of microbiome that is present in your gut. And improving gut mucus means you're improving or increasing the mucus layer. So how do you increase the proper kind of gut biome? That is done by increasing recipes which are rich in MACs, right? And if you want to increase the mucus layer, you have to eat food that increases SCFA, right? So what is it that increases MACs? MACs are increased by stuff like sauteed mushrooms, zucchinis, spaghetti, sprouted lentils, vegetables, tomatoes and cucumber salads, and vegetable salads. And SCFAs are produced when you have high fiber diets. So high fiber diets are fermented foods, cheese, pickles, yogurt, and high fiber diets. Uh, when you have lentils, when you have billets, or all of these high fiber foods, they also increase your SCFA. So what is MAC? MAC is microbiota accessible carbohydrates. So these foods, when you have them, they have more microbiota accessible carbohydrates, and therefore your microbiome improves significantly because of that, and that increases your gut health, because absorption also requires that you have all these typical microbiomes present. And SCFA, basically short chain fatty acids, are the ones that help you to have a good mucus layer, right? Short chain fatty acids also improve your cardiac health. They also improve your heart health, there's a blood pressure health. They also improve your diabetes health, specifically diabetes health. So if you have proper short chain fatty acids in your system, you will tend to have uh, almost no constipation. And they can be the SCFAs will be increased with high fiber foods. So the only thing that will increase SCFA are high fiber foods, along with these kind of fermented foods, cheese, pickles, yogurts. So this tells us about the two different types of diets that you can have. So on the left side is the diet that is considered to be the appropriate kind of diet, where you have fish, and you have a lot of fresh vegetables, you have a lot of fruits, and phytochemicals present in those foods. You have foods which have omega-3 fatty acids, they have high dietary fiber, and they have high MAC producing content and prebiotics. So there is a lot of SCFA which is present, and these short chain fatty acids enhance mucus secretion. And because of the other foods, phytochemicals, there is increased antimicrobial peptides, and this gut is regulated better with less oxygen radicals, which can harm the gut mucosa. And there is an upregulated tight junction, which means that these cells are tightly packed, and there is a junction in between which opens up when it needs to absorb the food. But these tight junctions are properly regulated so that only things that need to be absorbed are absorbed. And this functional intestinal barrier with good health, immune homeostasis, and a functional barrier is present. Okay, so dietary fiber degrading gut microbiome. So if your food contains these stuff, you have a very healthy gut. Whereas if you have food which is high in sugar, high in fat, high emulsifiers, there is enhanced mucus degradation, because that is needed to get all of these toxic substances out of the system. And there is a reduced antimicrobial peptide, and therefore you have more oxygen radical species, because there is more fight going on over there to get these toxic substances out. And there is downregulation of the tight junctions, and there is a dysfunctional intestinal barrier, which leads to more inflammation and leads to chronic disease, and therefore constipation. So a prokinetic, so actually this answers the question which many people have, that why is maida not considered healthy, right? Because maida comes onto the right side. It does not induce SCFAs. It does not have a very high content of MAC, right? It doesn't bring about actions which are similar, which are like dietary fiber, high dietary fiber type. So it doesn't increase your gut health. Whereas in this side, the gut health goes. So maida comes on the right side, and therefore it is considered not a great substance to eat too much. Prokinetic agents, a direct prokinetic effect on the colon has been demonstrated by senna preparations. So this is now treatment. Senna preparations, bisacodyl and prucalopride, tegaserod and cisapride. These are drugs that can be used. This last line is drugs that can be used to increase motility of the gut. Isabgol is something that many of us use here, which is the psyllium husk. And the thing is that it is rich in fiber and mucilage, okay, but it is bacterially non-degradable. So because it is bacterially non-degradable, it doesn't really contribute to long-term improvement in health. but it can contribute to an improved or a reduction in constipation or an improved motility in short term. Other laxatives that can be used are salts. There are soluble macromolecules. There are sugars which don't get absorbed into the blood, and there are stimulants like bisacodyl and senna we spoke about. Macrogol is osmotic water binding laxative. There are these salts, but they can cause a certain amount of tenesmus. Take home is that constipation is reliably diagnosed by Rome criteria. Organic disease of colon rarely manifests as chronic constipation. Colonoscopy or multiple colonoscopies are not needed. General measures often recommended are of dubious efficacy, and dietary fiber is worth trying, but it is not a magic bullet. Choice of laxative is based on constipation type and patient's individual tolerance and preference. Stimulating laxatives and macrogol have the best risk-benefit ratio. Purely prokinetic agents are unavailable without a prescription, so you would require some doctor to look into it. And a physician should individualize therapy and advise the best laxative to use. Maybe you might want to hear this.
5:30 तासाची फ्लाईट घेतलं, 6 तासाचा लेओव्हर होता. आणि सिंगापूर एअरपोर्ट काय अमेझिंग आहे. किती लोक गेले सिंगापूर एअरपोर्टला? आला तू गेला असेल नाही? तुम्ही गेला कोणीतरी गेलं असेल ना इकडे. काय मस्त बनवला ना एअरपोर्ट. तिकडे ज्युएल नावाचा एक प्रकार बनवला. असं मस्त फाउंटन ब्युटन आहे, झाडी बिडी आहे, पण ते मेन अट्रॅक्शन नाही. सिंगापूर ज्युएलचा खरा ज्युएल जो आहे तिकडचं वॉशरूम आहे. सॉरी मी हा शब्द वापरतो पण काय संडास आहे ना. अरे म्हणजे लहान असताना ना आईने जॉन्सनची पावडर लावली होती ना, त्याच्यानंतर त्या भागाची कोणी काळजी घेतली. बाजूला असं कंट्रोल पॅनेल माझ्या गाडीत नाही. तेवढे विचार सीट तुम्हाला हवी तशी थंड गरम करू शकता तुम्ही. पाण्याचा जेट पुढून आता पुढून येतो, मागून हवा मागून येतो. त्याच्यात पण टेम्परेचर वगैरे सेट करून तयार व्हायला खूपच अमेझिंग प्रकार यार. म्हणजे मला तर मी प्रार्थना करतो तुमच्यापैकी कोणी नेक्स्ट टाइम सिंगापूरला जाणार असेल, मी तुमच्यासाठी स्पेशल नवस बोलेन, तुम्हाला जुलाब व्हावा.
Thank you.
Thank you very much. On a funny note, your presentation was amazing. And it has, I've actually crossed out 3 questions that were sent to me. One was on isabgol, the other was an Indian style of toilets. Doctor, when you started your presentation, there was something about the Himalayan remedies. And
that's a joke.
It was a joke. But, the point is, and this is something which, and I'm sure you face this, a lot of people have your, home remedies, etc. Now, how much can you rely on them for a chronic case of constipation?
So can you mention what kind of home remedies you're talking about? Because enema is also a home remedy.
Yeah, no, I'm not talking about enema. Enema is still some intervention. I'm just talking about some, jari booty and whatever, which one has. May not be jari booty, but maybe just be some concoction which one has.
Yeah, Vaidya Pathankar Kadha, for example, was something that used to be available. I'm not sure it's still available. I had tried it once when I was myself a teenager, and I'm sorry, I didn't have a very fantastic experience with it. These are all stuff that can contain sometimes heavy metals. As long as they don't contain heavy metals, most home remedies should be okay. So for example, as we use ajwain, many times, they say if you're having a tummy ache, use ajwain. It's a harmless thing. It's something, it's a food edible product. And if you take it and you feel better, that's fine. There's really nothing wrong with it. So anything that doesn't have harmful products in it, and we try it, and if it works, it's fine. Because let's accept one thing, 30% of constipation is psychological. So if you have a psychological issue and you do something that kind of allays that, then you are and you're fine with it, then that's fine. Constipation, which doesn't have an underlying medical problem like a tumor, really is not something that's going to be a problem in the long run. So it's something that works, that's good. Sorry, you're not happy with my answer.
No, I'm very happy with your answer, but I'm saying you're saying all constipation is...
You actually, there are many times I look into a patient, maybe I get a colonoscopy done, or maybe I may get an enema done, and nothing really comes out. Because they have the system, the evacuatory system actually is extremely efficient in 90% of cases. It's only in very few patients that it does go ORI, an actual ORI. So the lazy bowel syndrome is actually very rare. If it is seen in patients, many times it's because they have consciously suppressed or they have used too much of laxative, and that's how it has come about. So in a natural state where there's been no interference with the standard way of existence, usually lazy bowel syndrome will be seen in very few patients.
Right.
One moment, please.
Yeah.
I am just finishing the webinar. 5 minutes. Yeah, I'm just finishing the webinar. 5 minutes. 7 minutes, yes. Sorry.
We'll make it really quick. There are a few questions which have come in. One is from Mr. Apurva Mehta, who's 80 years old. He says that he's been on aggressive medication for diabetes, heart blockage, and prostate, 16 tablets a day. His digestive system has been totally shattered over time. He eats salads and walks for 55 minutes every day without much effect. But what are the best laxatives he can have on a daily basis? This is Apurva Mehta.
I can't really give somebody who's taking 16 tablets and has 3 such serious conditions. I don't think I should be advising him without really evaluating him in detail. But for all practical purposes, polyglycol gels containing laxatives are considered relatively safe as long as it's not taken too much of water. So there's something called as Movicol, which comes as long as he doesn't increase his water intake, depending upon what cardiac condition he has, he can try Movicol. But if he's having a heart condition, he should get evaluated by a physician properly before he decides which drugs are safe for him, because almost every drug that is used as a laxative may have some effect or the other which is not acceptable. For example, if he's got a low cardiac output and he's also got kidney issues because of that, enemas, the standard enemas that are given are not acceptable for him. So
right.
This patient needs a little deeper analysis before any advice can be given.
Mr. Mehta, you should be consulting a doctor. Dr. Jaria is at the Hinduja hospital, and they do offer teleconsult if you are out of Mumbai city. We have a question from Mr. Ravi Gandhi, who's 62. He says he has a grade 2 fatty liver. Some years ago, the doctor said to be careful with what you eat. However, what symptoms arise and send alarm bells ringing, like say whether there'll be a pain in the stomach, to know we now have reached the highest grade 3 and will lead to cirrhosis. I don't drink much, but medicines are there. He doesn't have a question, but I guess he's just seeking advice.
Yeah, so basically fatty liver is a condition that is now beginning to come about as the nation and essentially the whole world is coming out of the state where earlier people used to eat once in 3 days to where people are consistently eating 3 times a day, right? So the liver, which is not used to handling so much in many patients genetically, is now handling a lot of food. And so a lot of fat gets deposited inside the liver, which increases the pressure inside the liver. So there's a test called elastography or elastography, which can be done, which will tell you what are the pressures inside the liver and will give you a rough idea of how you're progressing. And if you are progressing fast, then you need to do quite radical lifestyle changes, because fatty liver, if it progresses, cannot be reversed back. But if you picked up that you're having a fatty liver, then you can do lifestyle modifications which can halt the process from going ahead.
Right. There is a question over here, so I'll just address that. Doctor's presentation today will be there on the Seniors Today website on Monday evening, along with takeaways written by a medical practitioner, so you can look at that. The presentation was fairly information-packed, so you can have a look at that as well. Doctor, a few quick questions. Does consuming aloe vera alleviate constipation issues? Kumar Chakravarti asks.
Yeah, it's got a slight amount of effect by giving a certain amount of lubrication effect, but it also has mild irritant effect. So it causes osmosis to some extent. So it can help, yes, but not significant.
Is Sanjay Bhatia asks, Doctor, does constipation somewhere lead to piles?
Yes, it can. Yes, it can increase your tendency towards gaining onto piles. If it is chronic constipation and there is increase in pressures in the vessels there, that can lead to piles. Yes.
Doctor, this is a rapid fire kind of question. Triphala or Isabgol, which is better? This is Akhori Kumar.
Isabgol I can accept. I don't know about Triphala, about whether it is safe or not. I don't know of any cases that have come up who have used Triphala, but I do know that Isabgol would be okay and safe. It's basically psyllium. It does not get absorbed. It does not get metabolized. It only causes a certain amount of osmosis. It's considered fairly safe.
Right. Rajnikant Khilani says, Chawanprash acts as a good laxative for me. Is it okay to take it 2-3 times a week?
I wouldn't know. It's an Ayurvedic product and I have zero knowledge about Ayurveda. I really don't know.
There's Katie Dadanchi who asks, Doctor, would half a teaspoon of pure ghee with warm water first thing in the morning help to pass bowels regularly?
Well, yes, if it's helping you, you can take it. It's not going to harm you. It will cause it'll cause basically a gastrocolic reflex, which is fine. There are two kind of reflexes, gastrocolic and geronocolic, which can lead a person to feel the need to pass stool. So yes, warm water would help.
Dibyendu Ganguly asks, is Yakult an okay product?
Second, Yakult, yes, it's basically a probiotic.
Right. And this is a good note to end on. A question. Kamlesh Vajpayee, who's 69, are activities like regular walks good for keeping away the constipation?
A regular walk comes into exercise. Any amount of exercise is good for your health. So whether it's good for your gut or not is a different question. It is good for your general health, and so definitely it is something that will help you.
Great. Thank you very much, Dr. Jaria, for being here. Thank you to the Hinduja Hospital for facilitating this. It's been an excellent session, and you speak very well, Doctor. I must say that, and you should do more of these things, and I'm sure you are already doing it. But it's a very interesting session, a special session on constipation. To all of you over here, we will be back again next Saturday at 5 p.m. We have a special session on skincare. We have a dermatologist in the house, skincare for winter. Tomorrow we have the finale of the Seniors Have Talent. Be there, and of course, for all our events. Thank you very much, Doctor.
Subscribe now and press the bell icon. Never miss an update.